Okay, wishing you all a very good evening. And today I am going to talk to you about obstetric emergencies. This is a very, very important topic. And overall, obstetric emergencies are a thing which is a nightmare for us as intensivists. So this topic would help us tide over the crisis of managing the same in our ICUs. And as well, it's an important topic regarding exams as well. As we can find out that the magnitude and epidemiology of maternal near-miss incidence is really worrisome. Now, a prospective study of severe acute maternal morbidity and maternal near-miss events was studied in a tertiary care hospital in India, and it was found that the maternal near-miss incidence ratio was around 11.58 per thousand live births, and the maternal near-miss mortality ratio was 2.5:1, and the mortality index was 3.8% with SAM, and also near miss and 27% with life-threatening complications. So the incidence of maternal near-miss events varied widely from 3.9 to 379, quite a huge number, per 1,000 live births and 7.6 to 60.4 per 1,000 deliveries. Maternal death varied from 1.7:1 to 21.8:1. Incidence of high-risk pregnancy is approximately 15%. So incidence of high-risk pregnancy is approximately 15% in India, and at every 5 minutes, every woman dies from a pregnancy-related complication in India. Prevalence of SAM. So what is SAM? Severe acute maternal morbidity and MN, that is the near-miss events. This necessitates urgent medical intervention, and this can be as high as 8.23% in India. Is the slide seen? Is the slide seen?
Yes, yes, changed.
Okay. So, all complicated pregnancies require ICU care. Any pregnancy can develop life-threatening complications at any time with or without any warning. Care of critically ill patients is a unique challenge in obstetrics.
Voice is cutting in between.
That's probably owing to some network issues, Okay, let's see. When things go wrong in obstetrics, they go wrong fast. They just fall off a cliff. Medical conditions might present a risk to the pregnancy, and pregnancy may also modify the disease state. Drug therapy may be affected by altered pharmacokinetics during pregnancy, and this may also have an impact upon the fetus. Obstetric disorders constitute 2/3 of admissions, and 1/3 is due to pregnancy with medical disorders in obstetric HDU or ICUs. What is the most common antenatal complication for which the patient gets admitted to ICU? Pregnancy-induced hypertension or the hypertensive disorder of pregnancy. And postnatally, hemorrhage or infections are commonly implicated risk factors for ICU stay in critically ill obstetric patients. So what is different in pregnancy? Here, organ assessment is based on Apache score or SOFA score. Doesn't hold true. Why? Because pregnant population has got altered physiology. As you can see, there is difference in the pregnant and non-pregnant patient as regards to respiratory parameters, cardiovascular physiologies, and also the hemodynamic parameters. Coming to the pregnant patients, we find that the pregnant patients have a higher respiratory rate, high tidal volume as compared to non-pregnant patients.
Stop.
Hello? Yes? The vital capacity is nearly same, 3200 as in pregnant and non-pregnant patients. Expiratory reserve volume is low, that is 500 ml as compared to 700. Inspiratory reserve volume is more or less same, FRC low. That is why they have very poor respiratory reserve as compared to non-pregnant patients. Residual volume also is low. Pregnant patients have a slightly alkalotic range of pH. They have normally low level of PaCO2 as compared to non-pregnant patients. Normal PaO2 in pregnant patients is between 100 to 110 as compared to 90 to 100 as in non-pregnant patients. Pregnant patients usually have slightly raised resting heart rate as compared to non-pregnant population. Cardiac output is also on the high side, 6 liter per minute as compared to 4.5 liter per minute as in non-pregnant patients. The systemic vascular resistance and the pulmonary vascular resistance are lower as compared to non-pregnant patients. CVP is more or less the same. However, the colloid oncotic pressure is lower as if 16 to 18 as compared to 22 in the non-pregnant patients. Now, coming to the hematological parameters, hematocrit is between 0.30 to 0.34 as compared to 0.4. Hemoglobin 11 to 12. We all know pregnant patients have got a physiological anemia. RBC volume is low as compared to non-pregnant patients. ESR is on the high side. WBC count is slightly high. There is a tendency of neutrophilic leukocytosis in pregnant patients, and there is a generalized expansion of plasma volume, 80 to 85 ml per kg in pregnant population as compared to the non-pregnant population. Hence, there had been an introduction of mu score, modified early warning score, which has been modified in the pregnancy in mute and moist score. And you have to first identify what is the problem. Then you need to escalate the situation. So this is a method of triaging which patient you need to keep in ward, which patient need intensive monitoring as in ICUs and HDUs. So what are the parameters based on which this score is done? Respiratory rate, oxygen saturation, any supplemental oxygen the patient is receiving or not, temperature, systolic, diastolic blood pressure, heart rate, level of consciousness, pain, excluding labor pain, discharge, any lochia, and also proteinuria. So first you have to identify with this score system. So as you can see from this table, there are 3 color charts, right? This one is the red pathway, one is the amber pathway, and the other is the green pathway. And then based upon this, you need to escalate. Deteriorating obstetric patient escalation algorithm. So these are the chart based on which you need to escalate the patients. Okay. So if it is a green pathway, total score is 0. You may continue routine 4th hourly observation. Repeat observation if the patient condition changes. Total score is between 1 to 4. Inform the nurse in charge or the midwife who must assess the patient immediately. And they are the persons who would decide if increased frequency of monitoring and or escalation of clinical care is needed. If concerned about the patient, you need to consult the senior house officer. If symptoms of preeclampsia is present, then you need to lower the threshold for escalation of therapy. Okay. And also, last but not the least, need to document all the actions. Coming to amber pathway. Here the total score is between 5 or 6, or if any of the individual parameter is equal to 3. Then you need to inform the midwife or nurse in charge, that is consider critical care outreach. They need to immediately review the patient and contact middle grade doctor obstetric, and also necessitates early consultant involvement. Inform obstetric anesthesiologist as well. Care to be provided here in this amber pathway in an appropriately monitored environment, preferably in HD or ICU care, and increase the frequency of observations to 1 hourly. However, the threshold for escalation needs to be lowered down if the symptoms of preeclampsia are present, like headache, visual disturbances, or abdominal pain. And also, last but not the least, have to consider whether the patient is having sepsis or not and document all the actions. Coming to the red pathway, where the score is more than equal to 7 or acutely concerning regarding sudden deterioration. Here, what you do, how do you escalate? Contact the middle grade doctor obstetric and obstetric anesthesiologist immediately. Consider 2222 for obstetric emergency team. Inform the midwife, nurse in charge. Continuous monitoring of vital signs is required and immediate referral is required to ICU or HDU. And also consider the critical care outreach team. So these are the pathways by virtue of which you can identify early, escalate early, and provide an appropriate care to the patient in the monitored environment. Now, how to treat? If you consider why was the need for algorithm, it had been found that if there is an algorithm, it is easy to identify the patients earlier. Based upon the physiological parameters, you can do triaging and then follow the clinical pathway, the green, amber, and red pathway, and refer the critically ill obstetric patient to the ICU HCU consultants so that the near miss events can be avoided. So, if you consider over here the parameters, what are the yellow triggers? This is mute, identify risk. The yellow triggers are systolic blood pressure less than 80 or 156 to 160, diastolic less than 45 or 106 to 110, heart rate either less than 50 or between 111 to 130, respiratory rate either bradypnea less than 12 or tachypnea, that is more than 25 to 30, temperature, hypothermic patient less than equal to 36, and oxygen saturation in room air between 90-93% or altered mental status. What are the red triggers? Nursing clinically uncomfortable with patient status, sudden acute alteration in the patient's physiological parameters, temperature more than equal to 38, respiratory rate more than 30, saturation in room air less than 90, heart rate more than 130, systolic blood pressure more than 160, respiratory rate more than 30, diastolic blood pressure more than equal to 110, mean arterial pressure less than 55. Okay. So, a single red trigger or two yellow triggers requires evaluation by the provider. Abnormal vital signs must be sustained over at least 20 minutes to consider it as a trigger. So, how to treat? So, maternal triggers, we have all evaluated the maternal triggers. Now, if there are no abnormal triggers, what do? You stop here, continue to monitor. And if there is one abnormal trigger, then what do? You still need to monitor and observe. If the abnormal maternal assessment shows two or more triggers, then you need to do evaluation of the patient and continue towards the critical care assessment pathway. So, what are the things that you need to consider? Infection or sepsis, or whether there has been any cardiopulmonary deterioration of the pregnant patient, that is in the form of cardiomyopathy or congestive heart failure, myocardial infarction, pulmonary edema, pulmonary hypertension, pulmonary embolism, deep vein thrombosis or illicit drug use, hypertensive disorder of pregnancy, obstetrical hemorrhage if it is present, if any. Now, coming to pregnancy-induced hypertension or the hypertensive disorder of pregnancy. So, for talking about this pregnancy-induced hypertensive disorders, we need to know that hypertension in pregnancy can also be because of chronic hypertension, gestational hypertension, preeclampsia, eclampsia, chronic hypertension with superimposed preeclampsia, preeclampsia with severe features, severe hypertension and hypertensive emergencies. Now, chronic hypertension, where systolic blood pressure is more than equal to 150, 140 or diastolic blood pressure more than equal to 90, pre-pregnancy period or in a gestational age less than 20 weeks. Gestational hypertension when SVP is more than equal to 140 or diastolic more than equal to 90 on at least 2 occasions, at least 4 hours apart after 20 weeks of gestation in a woman with previously normal blood pressure, absence of proteinuria or systemic signs, symptoms. Preeclampsia, eclampsia, where systolic blood pressure more than equal to 140 or diastolic blood pressure more than equal to 90. Proteinuria with or without signs and symptoms. Presentations of signs, symptoms, lab abnormalities, but no proteinuria is present. Mind it, proteinuria is not required for diagnosis of eclamptic seizures in a setting of preeclampsia. Chronic hypertension with superimposed preeclampsia occurs in a woman with history of hypertension either before pregnancy or before 20 weeks of gestational age. Now, severe preeclampsia. What are the sinister features? Systolic blood pressure more than equal to 160 or diastolic blood pressure more than equal to 110 can be confirmed within a short interval to facilitate timely antihypertensive therapy. Thrombocytopenia with platelet count less than equal to 10 to the power 5 per microliter. Impaired LFT that is not accounted for by alternative diagnosis and as indicated by abnormally elevated blood concentrations of liver enzymes to more than twice of the upper limit of normal, or by severe persistent right upper quadrant or epigastric pain unresponsive to medications. Renal insufficiency, where the serum creatinine concentration is more than 1.1 milligram per deciliter, or a doubling of the serum creatinine concentration in the absence of other renal disease. Pulmonary edema, new onset headache unresponsive to medication and not accounted for by alternative diagnosis, and also some visual disturbances. Now, how do you define severe hypertension? Where systolic blood pressure is more than equal to 160 and or diastolic blood pressure more than equal to 110, measured on 2 occasions at least 4 hours apart. Hypertensive emergency is persistent severe hypertension that can occur antepartum, intrapartum, or postpartum. It is defined as 2 severe blood pressure values that is more than equal to 160 by 110 taken 15 to 60 minutes apart. However, these severe values, they do not need to be consecutive. Proteinuria, 300 milligram or more per 24-hour urine collection, or protein creatinine ratio of 0.3 milligram per deciliter or more, or dipstick reading of 2+ used only if other quantitative methods are not available. Thrombocytopenia, where the platelet count is less than 10 to the power 5 cells per cubic millimeter. Now, coming to the pathogenesis of preeclampsia, as you can see from over here, there can be pre-existing risk factors like chronic hypertension, diabetes, and antiphospholipid antibodies, genetic factors like FLT1, SNPs, and trisomy 13, immunological factors like DNK cells and Treg cell imbalances. All this leads to shallow placentation, which in turn leads to reduced placental perfusion because of oxidative stress and intrauterine growth restriction. This occurs in stage 1, that is in first and second trimesters. And next, in stage 2 or third trimester, there is increased circulating SFLT1 and SENG. So what is SFLT1? It is soluble FMS-like tyrosine kinase 1, and SENG is soluble endoglin. So these are actually the angiogenic inflammatory factors. All this leads to systemic vascular dysfunction, capillary leak, and vasospasm, and henceforth it leads towards proteinuria, glomerular endotheliosis, coagulation abnormalities as in HELLP syndrome, cerebral edema, leading to seizures as in eclampsia, angiotensin II sensitivity, and leading to hypertension. So who is at risk? Maternal characteristics and history provide strong clues due to which women are more at risk of developing preeclampsia than others. Particularly, the population who are at risk are history of prior preeclampsia, chronic hypertension, multiple gestation, pre-gestational diabetes mellitus, maternal BMI more than 30, that is severely obese patients, having antiphospholipid syndrome or SLE, and those who have underwent assisted reproductive therapies. So, How can these be diagnosed? It may be actually possible to narrow the risk profile for preeclampsia further using a combination of these risk factors, screening of uterine artery Doppler as well as plasma PIGS. Okay.